We welcome you all to Talk the Talk. My name is Janine Stiene,
And I'm Toni-Ann Antoniato.
the Masters of Myofunctional Therapy.
Together, we interview physicians, dentists, and other professionals to learn how their expertise can benefit you, your child, or your patient's speech and language skills and complement the services they are receiving. We welcome Dr. Barry Raphael to this episode of Talk the Talk. Dr. Barry is an orthodontist and specialist in the field and a true leader in the field of orthodontics. Dr. Barry is the owner and orthodontist at the Raphael Center of Integrative Orthodontics in Clifton, New Jersey. Dr. Barry lectures around the world, teaching other professionals about the importance of airway health in orthodontics. We are lucky enough to share some patients with Dr. Barry. Some of our Long Island speech patients travel to New Jersey to be under the specialty and care of Dr. Barry. Thank you, Dr. Barry, for joining us today. Welcome to this episode of Talk the Talk.
Thank you.
Well, thanks a lot, and good morning, and hello to your audience, and I look forward to our discussion.
Thank you. So just to start, if we could talk about for our audience to understand, what is integrative orthodontics? What is airway orthodontics?
So let me start off by drawing a big picture for you. This past weekend, I spent time with a conference sponsored by a group called Documenting Hope. I don't know if you've heard about it. Beth Lambert is a mother of two kids that had terrible allergies, and she worked them out of it by an integrative approach that include changing their diet, their exposures, their increasing their resilience to the environmental impact of things that are going on around us in our modern world that frankly are challenging us. And she was so successful at it that she decided to help other mothers. Um, I, I, I'm going to make a plug for her because I'm so proud of the work that she's doing. She created a website called Epidemic Answers. She started this group called Documenting Hope, whose ultimate objective is to create a clinical study subjecting 14 children with chronic non-communicable disease to 18 months of kitchen sink treatment. In other words, all the things that we know about these chronic ailments and how they're influenced by inflammation. There are so many different approaches, and you guys exemplify that because I know you're working with kids with special needs, and in a controlled way, but in a broad way, subject these people to the things that we know that can help reduce inflammation, and see how well we can, how well we can make them. Sometimes there are cures for things that we never really thought there were cures for, simply because we're now starting to look for underlying causes. And this is not just in our fields. This is a phenomena, I think, that is starting to take root in medicine, as well as dentistry, as well as allied health, where we're understanding that treating symptoms is just insufficient,
Yep.
that it solves an immediate problem, but because it doesn't really address the root cause of the problems, um, it has, frankly, unintended consequences. Just not only are symptoms prolonged, but they require us to use compensations that have unintended consequences. And we see this all over medicine and dentistry. And once I started to realize that that's exactly what was going on in orthodontics, it really made me change my mind about things. So the big picture is this. We have a wonderful new world that we've created. We have ample clothing and shelter and food. If we're lucky enough to live in a place that's not, say, at war or, undeveloped, or, there's so many things to be grateful for, as well as so many things to be ashamed of as being a human being these days. It's hard to separate those, but really we have conquered a lot of our survival needs, right, in this new and modern world, and yet the unintended consequences may in fact be signaling our doom. That many of the chronic, non-communicable diseases of civilization or Western lifestyle, however you want to say it, that are ailing us are making us sicker and sicker, to such an extent that children, who frankly tend to be the canary in the coal mine, they are expressing these things earlier and earlier in life. They are winding up in a position where they are having difficulty becoming independent. I don't know what if I should say useful, but contributing members of a society that will be able to assure our future as a species. It's it's getting to the point where many kids will not be able to have an independent life, that they will need to be taken care of for the rest of their lives. And whether they're going to be able to find someone to love and raise a family with or hold a job, it's becoming more and more in question. They highlighted the statistics about this chronic disease epidemic at this conference, and suggested that, especially over the past 100 years, that the epidemiology it's skyrocketing. It's increasing exponentially and a little bit scary. So where does crooked teeth come into this? Crooked teeth have become this cultural piece where we think that we need to have perfect teeth so that when we smile, people will adore us. And I suppose that we have the luxury in our modern world of doing that, and certainly the practice of orthodontics has increased in its sophistication and technology and ease of use and deployment and all that, so that people can have crooked teeth. I mean, straight teeth, and it's fine. But when I started to realize, after practicing orthodontics for 3 decades, that the incidence of crooked teeth was getting worse, not better, it really made me think hard about what I was doing. In fact, a recent paper out of France suggests that 88% of kids in France now have crooked teeth.
Wow.
Wow.
Wow is right. But I am an orthodontist. I should be happy about that.
Yep.
But what I also realize is that the etiology of crooked teeth has absolutely nothing to do with the teeth themselves.
Yes.
And in fact, and you probably know this, and maybe your audience knows this, but I didn't know this when it finally struck me, and this is, I don't know, 2008, that soft tissue dysfunction is the etiology of malocclusion,
Mm-hmm.
right? I take that quote directly out of a paper by Herman Ramirez up in Toronto. And um, yeah, I mean, even orthodontists, we all understand that thumb sucking and tongue thrusting and, some pacifiers and those kinds of habits can make teeth worse. But it's more than that. That soft tissue dysfunction is probably at play in every case of crooked teeth. And why do crooked teeth happen? Because soft tissue dysfunction or soft tissue function is responsible for helping grow and mold the shape of the bones of the face.
Mhm.
And again, this, but when you can hold your tongue on the palate at rest, the tongue serves as a scaffold for the growing jaw, and it forms a nice broad wide palate, and it grows forward in the face, and the tongue fits up in there and helps guide the teeth into place in a nice beautiful arc. Humans used to have room for 32 straight teeth.
Mm.
32, mind you. In other words, their wisdom teeth
Yep.
could fit, right?
Mhm.
And I nobody ever told me this in ortho school. Nobody told me in dental school, but I came to learn that human beings always had straight teeth, that crooked teeth were a very rare phenomenon, that with some interesting exceptions throughout human history, but very little. And that anthropologists have been trying to tell us this for over 100 years, that the genes for teeth in humans are for straight teeth.
Mhm.
There are no genes for crooked teeth. There are only genes for straight teeth. Yeah.
Wow, that's interesting.
And right. But what has happened because of this change that we've made in our modern world? We've changed the way that we eat, changed what we eat, we changed what touches us in our skin, what we drink, what we breathe, how we use our jaws, how we use our tongue, how we use our bodies. Um, and while providing unlimited food and clothing and shelter would seem to be a good thing, it has also been accompanied by a collapse of the way our faces take shape.
Mhm.
Now, if the only result of that was crooked teeth, maybe it wouldn't be so bad. We just put on braces, straighten teeth. But what we also have learned is that when the jaws don't grow enough to accommodate the teeth, they also tend to lead to smaller breathing spaces,
Yeah.
another major function of our face. And to such a degree that either early in life or later in life, we're having enough trouble breathing that it is leading to, guess what? A chronic non-communicable disease of modern life, sleep apnea,
Yep.
flow limitation, disturbed sleep, um, and not sleeping well. We are now understanding more than ever is critical to our physical and mental function. When you don't breathe well, it is itself inflammatory. And so suddenly, my profession is really not about straightening teeth at all. It's about helping children develop an optimal physiologic airway and breathing pattern. And because of the incidence of chronic disease, the sooner you do that in life, the better off the child is going to be.
Absolutely.
Is that?
Isn't that a major shift?
Yes. Yeah.
I get to the point where I've helped a child, and the jaws are looking nice. Soft tissue dysfunction is more or less tamed. They're sleeping better, they're breathing better. And then the teeth come in, they don't always come in Hollywood perfect.
Mm-hmm.
And you know what? I don't really care. I mean, if people still want Hollywood perfect teeth, It's easy to throw braces on or aligners or however you want to push the teeth around. And I'm happy to do it. And frankly, I do enjoy it. I always enjoyed orthodontics.
Mhm.
I love working my hands and the appearance of beautiful straight teeth.
What
But
is what?
well, yeah, let me because the thing about orthodontics is that if you don't address the etiology of the problem and address the way the face is growing, the way the soft tissue has to act, you're going to wind up with these other chronic problems, whether you straighten the teeth or not.
Mhm.
And just by straightening the teeth, you are, in essence, ignoring the incidence of those other problems. Um, orthodontists, by and large, we are very quick to say that doing orthodontics, whether it's by expansion or extraction or headgears or whatever crazy contraptions we use, that it does not cause sleep or breathing problems. And it's correct. It does not cause sleep or breathing problems. What they don't realize, and what I didn't realize for 3 decades, was that if the teeth are crooked, those problems are probably already there. And the techniques that we use to straighten teeth in jaws that haven't filled out or don't match, they tend to lock the problem in so that there's not all that much you can do about them once you've finished, the orthodontics. Perfect example of this is when it there's a big overbite. And generally, um, the way I was trained, that overbite or angle classification number 2 would indicate that either the top teeth have to go back or the bottom teeth have to come forward. And sometimes it's a mixture of both. But when you pull top teeth back to meet a short lower jaw, you have essentially doomed it to that position for the rest of the person's life. And if there was an extant breathing problem because of a narrow or collapsible airway, that's it. That's what they've got. And so the big picture, moving back to where I started, we are, if we're not careful, we are dooming patients to a lifetime of struggle, of breathing, of soft tissue dysfunction, of facial deformity, frankly. I mean, oh, if you look at movie stars or rock stars today, they tend to have tiny faces. We like that because they're our stars, and we've gotten used to it. And I don't know that we really want to go back and look like paleo people right away.
Right.
But the anthropologic standard is our genetic inheritance. And if we're going to conquer this problem, we have to get our faces to grow better again. Otherwise, we are subject. So, all right, um, documenting hope piece.
Yeah.
Just to go back to it, it was a collection of practitioners of all sorts. There were speech therapists and myofunctional therapists and dentists and physicians and naturopaths and osteopaths and craniosacral therapists and nutritionists, all sitting together in a room talking about how much the kids are struggling and how we have to, in essence, relieve them of this struggle. Um, it, it, it seems as if the common thread among all these chronic non-communicable diseases is overwrought inflammation of the body. That inflammation happens to be one of the things that helped us survive because it helps us fight infection and it helps us repair wounds and it helps us stabilize different processes of the body. But it's been called into play so much in this modern environment that we are we're struggling with the intensity of the inflammation and the duration of the inflammation. There's no rest. We we are um, we're exhausted. Our
Mhm.
bodies are exhausted trying to fight off all the things that are ailing us.
We're seeing more and more dental practitioners carrying or selling or whatever, endorsing those sleep studies, the take home sleep study,
Hmm.
so that they can bring the results with them to an ENT, I guess, to be a little more proactive.
Mm.
Um, which,
Good. I love to hear that.
yes, yeah, I didn't know if that we see that you'll see that as the norm moving forward.
I think we will.
Okay.
One of the things that dentistry, I think, has a little bit gotten stuck in is this idea that the problem is sleep apnea. The sleep apnea is really, well, by definition, it's when you stop breathing.
Right.
And if you want your insurance company to chip in to help treat it, you have to be choking for long enough and enough times during the night that they'll qualify you. Uh, but nonetheless, sleep apnea, while it's a terrible problem, does need treatment, and we can help, is not the real problem. It is itself a symptom of an underlying problem.
Okay.
It's kind of the end stage of the problem.
Mhm.
More prevalent is this idea that that we are struggling to breathe both day and night. In fact, the only reason our sleep is disturbed is because we just can't use the same compensations at night that we do during the day.
Mhm.
And so we struggle more to breathe at night. A lot of people call it sleep disordered breathing. It's really not. It's breathing disordered sleep,
Breathing.
Mhm.
Yeah,
you know,
exactly. Yep.
right? Just to put a fine point on it. So, yes, I'm happy that the profession is starting to take notice and starting to take action and absolutely discovering what's going on at night is a significant um, data point for knowing what to do for children.
Absolutely. And it's the parents being educated, but it's also the providers being
Yeah,
educated.
yeah.
But is it that next generation of providers? Like, do we have to wait for those in practice to retire and that the next generation will
Yeah,
be educated in this manner?
yeah, I
I don't
guess so.
know. Is that
I was an old fart when I learned.
you're not exactly. You're only as old
Uh,
as you feel.
do you see my white beard here?
I have some white
I
in
am
me too.
I am no spring chicken, and for lots of reasons, I could have. In fact, I did ignore this problem earlier in my career a
Okay.
number of times. Why it finally settled in on me after reading that article by Ramirez, I don't know, it was just sort of my natural curiosity about always wanting to find a better way to do what I do.
Right.
A lot of my a lot of practitioners, they get into it because they start seeing it in their own families.
Okay.
Okay.
Mhm.
They're seeing it in their kids.
Mhm.
Old guys like me, we start seeing it in our grandchildren,
Yep.
and we say, all right, maybe there is something to this.
Right.
And then once you start seeing it, you probably know this. Once you start seeing kids walking around with their mouths hanging open, unable to breathe through their nose, slouching, holding their head forward, um, as bare minimum, you start seeing it everywhere. You realize that this is an endemic problem in our society,
Mhm.
and um, mouth breathing is the least of it.
So are
Crooked
you
teeth is the very least of it. these other highly inflammatory problems. This is what we were talking about at Documenting Hope, where autistic spectrum disorders, PANS and PANDAS.
Yep.
Do, do you know, you guys are familiar with PANS and PANDAS? You probably see these kids all the time.
Mhm.
And I had been a little aware of it, but what I now understand is that in order to be susceptible to having strep trigger such an acute psychiatric disorder, your body already has to be quite taxed.
Mhm.
That it doesn't come just out of having really just a strep infection.
Yep.
That it happens when your body is already aflame, already already predisposed to an inflammation that gets so bad that it crosses your blood-brain barrier and starts to literally attack your brain. That is really frightening.
Mhm.
Um,
If
Crohn's and digestive disorders, uh, asthma and allergy and breathing disorders, eczema and skin problems. The list goes on. I mean, every system of the body is subject to, number one, hyperinflammation, and number two, poor oxygen distribution. I I I understand about oxygen distribution, and it was really one of the first things I learned as I started changing um, my thinking about this. And it was not really well covered at this event, to tell you the truth. Um, I know a lot of people are familiar with Buteyko and Patrick McEwen's books, Shut Your Mouth and Learn How to Breathe Through Your Nose and Reestablish End Tidal CO2. And it actually is an important part of my practice, not because I want to be a pulmonologist or an ENT, but I got to get the kids to shut their mouth and put their tongue on the palate.
Yep.
And
You're
they
the
won't do that unless they're comfortable breathing through their nose. And they won't do that unless they can tolerate the buildup of CO2 that makes them feel like they're out of breath.
Dr.
So,
Barry, if
yeah.
you are an airway integrative orthodontist, do you
Yes.
intervene earlier because you're trying to maximize space? You know, we're always told don't send to the ortho until 7. Some places say 9 because we're not going to expand before then. But I would think it would be the opposite if you wanted to maximize airway.
Yeah. So much so. We're it's taken me a while, but I'm now building our Littles program, which is 0 to 3 years old.
Okay.
I typically start at 4 and 5 if I want to help a child grow gently help develop, well, help reverse the trajectory of growth to one where they're going to have plenty of room for the tongue, plenty of room for the teeth, where the face is going to grow appropriately broad and forward. I can do that with very gentle techniques and training. We use a myofunctional training technique. We use the light wire expansion, which is not a palate expander per se. It is something that just helps redirect the trajectory of growth, the direction of growth. But even then, well, I mean, even at 4, let's say this, the signs of poor facial growth are already there.
Right.
I mean, just look at baby teeth. If there are no big spaces between the baby teeth, your jaws have not filled out well.
Yep.
And dentists know this, and orthodontists know this. Or at least it was mentioned in an introductory chapter in a book that we probably since forgot because we're so into putting on braces.
Yep.
But that's well known. Now, if you see a 4-year-old and there are no spaces between the teeth, are you going to let that fester for another 3 years, let alone another 7 or 10 years
Right.
before it's time to put on braces?
Right.
If it were only about the teeth, fine, but it's not.
Right.
When the jaws are not growing well, the child is susceptible to all these other problems, and which will increase the inflammatory load that they're carrying. We cannot, in good conscience, anymore ignore that.
Right.
So the Littles program at 0 to 3, it's not quite so much about appliance driven or even training, but well, as you know, there are a lot of things that can be done for a 2-year-old, say. You know, there are oral motor approaches and teaching swallowing and expression and expressiveness and putting together lots of parts of meeting developmental milestones that they may not be meeting.
Yep.
Most mothers don't want to ignore that. Oh, he talks so cute. He lisps. I
Oh,
think
yeah.
I think we
Children
won't do
love that.
anything about that till he's interested in girls at 14.
Exactly.
I mean, come on. Yeah,
Exactly.
there's so many signs. So um, there are manual therapies, especially craniosacral and cranial osteopathy, that can address some of the tight spots, the fascia, the restrictions, the um, the remnants of a difficult birthing process. I mean, think about it. I'm a man. I shouldn't even be talking about this. You guys talk about this. Birthing is a tough experience,
Is
right? For
Yep.
women, it is just as tough for babies.
Yep.
They go through every bit as much trauma as you do, and if they have a good APGAR score, it's just the rest of it's ignored. It's just it becomes unconscionable again to just ignore these things when the treatments can be very simple. We started bringing in healing laser. We're doing the photobiomodulation piece that will help release fascia, that will help reduce muscle strain, which will help open up sutures. But it really has to be done in a collaborative environment. Um, Having some manual therapy and some oral motor therapy. Um, I've been doing a piece called the neonatal ALF. It's not a metal piece at all. It's more of a what dentists might recognize as a base plate. We used to use base plates for making dentures. You know, it's that initial covering that goes over the gums. Well,
Yep.
I do that for the babies and create it in a way that it attracts the tongue to the palate, that with every push up from the tongue, it simulates a cranial, uh, a cranial adjustment. And really, it starts to teach the tongue how to get to the palate. I mean, we'll come up with all kinds of things to help babies get off to a good start.
Yep.
Um,
Is
my
there a
friend
standard
Kevin,
teaching for orthodontics? Like if you're going into the field at this point, do
yeah,
you have to pick a program, like one that's all about the teeth and one that's all about the airway, or is it a common theme and part of all programs?
yeah, it's not a common theme at all.
Okay.
Um,
And that's how we
I
feel too. Yeah.
yeah, in the past several years, though, a number of the orthodontic programs have publicly started to give at least lip service
Yes.
to the issue. I know I know for a fact that it's very difficult to change a dental curriculum because there's so much that they feel that kids need to learn,
Yep.
about well, in the case of orthodontics, about putting braces on and treating different cases. And most orthodontic schools, they don't show up the patients don't show up until they're ready for braces.
Right.
So a lot of the programs are just oriented to orthodontics. A recent paper came out of Stanford by one of the orthodontic assistant professors there. Can you hear my dogs barking, by the way?
No.
No.
No, good. All right. Audrey Yoon spearheaded a paper that included an all-star lineup of people from Stanford, from and some other schools, including a prominent medical researcher, including a sleep physician, including a sleep psychologist, including an oral surgeon, a really broad background. And this is the first time I've heard it come out of a university setting that we are responsible for helping faces grow in an appropriate way, and that there are things that we can do from very early age.
Mhm.
And I thought that was fantastic. And while I think there are things they can add to it, I don't want to be critical in the least, because they're really headed in the right direction. I recently got an invitation from Montefiore to start lecturing about this material there. I start in December.
That's great.
That's great.
And yeah, and the attitude of the head of the department, Miraj Ahmed, is very open to this material
Mhm.
and realizes that it is something that the kids need to be taught.
Mhm.
So I think things are coming around. I don't want to be pessimistic at all. There was a program up at Boston. Tufts has been paying attention to sleep apnea. Um,
So where does it all start?
Aiken
Does it start
Still
with the frenum from the pediatrician and the frenum post delivery, or does it start dentist once they get to the dentist? Pediatrician, who's the one that would be the first person to point out and say, okay, this is where I need to start at this age with this problem in order to maximize the airway? Bless
You
you.
mean just in general,
Yes.
how we want to teach this thing? Well,
Yeah.
yeah. I mean, first of all, there are exposures that mom is having while pregnant that have to be controlled.
Mhm.
That mom's inflammation becomes baby's inflammation.
Got it.
So what she's eating, what she's exposed to, the way she's dealing, we're understanding that sleep apnea in a mom, especially in that third trimester when you're carrying around that huge package under your diaphragm, that becomes intermittent hypoxia for the child.
So, question for you.
Sure.
Is it ever too late? So, we have a lot of patients who come to us later on. They've already under the care of an orthodontist, and we didn't maybe do all the things that would support helping their airway. Is it too late for adolescents to, reverse and, go into maybe under someone like you's treatment? Is there things that we can make better?
Yeah. So is it ever too late to do myofunctional therapy?
No.
No. But I do, in my new understanding of things,
Mhm.
um, it is unfair to expect myofunctional therapy to undo the damage that has been left and propagated by orthodontic treatment. That I kind of realize this, well, first of all, you may be interested to know, in my orthodontic training way back in the 80s.
All
See,
the
I
way back
am
then?
advanced.
All the way back then,
80s,
huh?
early 80s, may I say,
Uh-huh. Oh.
that we actually had a course in myofunctional therapy. But Bud Fogel was a contemporary of Dan Garliner, Dan
Yeah.
was out on the West Coast. Bud was here on the East Coast, not quite as prominent, not as much of a promoter or showman, but was avidly practicing. And I was interested. I listened to the lecture. I kind of got it. When I got out, if I ever thought I was in trouble because of soft tissue dysfunction, then I would make a referral to a myofunctional therapist, and I had a couple in the area. But trouble meant that the braces weren't working the way that I wanted them to.
Yeah.
Mhm.
Right. And so it would usually be at the end of a case, say when I'm trying to bring teeth together and something is not allowing them to come together. No matter what I do, I could throw spikes at the tongue, I could do elastics, I could do fences, and yet nothing seemed to work. And that's when I would send for myofunctional therapy. I now realize that was entirely unfair.
Yeah.
It, it's like it's like yeah, it's like being a fireman who's called after the house is already halfway burnt down.
Mm-hmm. And
I
that's the
mean,
fault.
yeah, you may be able to put out the fire, but the house is still going to be a mess.
Yep.
And so if orthodontists become a little more familiar with this, that's fine. But until they realize that soft tissue dysfunction is present at the beginning of every case, not just at the end of the case, then we're not going to be really making, big progress.
Mhm.
And they're not going to make that big a change because, frankly, most of the time you can get away without myofunctional therapy and get the teeth straight. So they don't have the impetus because we are good at straightening teeth. What is going to change things is when they start to realize that it's not about the teeth,
Right.
that it's about the soft tissue dysfunction, the shape of the face, the flow of the air, and all the ramifications from there.
Mhm. Mhm.
So
So if you had to
and,
intervene early, what would be the first thing if you were looking at an infant? Would
uh,
you look at the frenum?
oh yeah. So we were talking about that. So we talked about prenatal,
Right.
but okay. So at birth, there are a couple things that definitely should be looked at. Number one is the frenum, especially if it leads to some difficulty in latching and breastfeeding. Breastfeeding is so important, not only because it provides the right kind of nutrition for a baby, but it provides the kind of strength and coordination training for the jaw and the tongue that will lead to better outcomes in facial growth. Um, it also leads to better breathing outcomes too, because in order to breastfeed for 10 or 15 or 20 minutes, you have to be able to breathe through your nose.
Right.
Otherwise, you got to quit every, you know, 20 seconds or whatever it is. So when the frenum is restricted, of course, that makes it difficult for the baby to latch.
Mhm.
The other thing is looking at cranial and sutural health right off the bat. That the craniosacral therapists that are trained with infants, the craniofacial therapists, the cranial osteopaths, the first thing they say is if we could get our hands on a baby when they were born, their outcomes would be much better.
Wow.
Wow.
And yeah, because again, it is a tough experience, and trying to fit your head through what is otherwise the size of a toilet paper roll,
Yeah.
it's just not an easy thing.
No.
And even with C-section, the babies are often crammed up against the pubic bone for hours and hours and hours before somebody finally calls it. And then frankly, if it's a scheduled C-section, the baby's head doesn't go through that necessary a process of folding in, the bones of the head fold in on itself. There's a lot of stimulation that happens. We also know about how the microbiome gets seeded by a vaginal birth. Just so many little things that we can improve in the birthing process. From there, babies are suffering their own whole list of inflammatory problems that are often being written off by physicians as sort of either normal or normal struggles that they'll grow out of, so we don't really have to do anything about it, without realizing that these things all have longer term unintended consequences to them. So, yeah, I'm an advocate of starting from the beginning. I do have a case. In fact, I'm doing the consultation tomorrow. The father is a pediatrician
Okay.
who has never met me,
Okay.
knows nothing about me, and or I haven't even done the treatment plan yet. And he is threatening to report me to the state board because his wife is insisting that the baby come see me. It's not
Wow.
even a baby
Wow.
anymore. He's already 4 years old. And I say this because there's as much resistance and change that is needed in medicine, and definitely in pediatrics, as there is in dentistry. And those of us in dentistry who understand how important this is, we are often frustrated by the pushback that we're getting from the pediatricians who think we are over treating.
What do you think that it's not going to change until the entire generation changes? Is it going to be like, are we
Well,
20 years
it
out?
is it is often said in the history of innovation that you have to go through a generation who isn't digging their heels in to protect the status quo.
Yep.
So I do think that that things will get better. But I also know that this is a serious problem that's going to require a solution that spans over several generations.
Yep.
That we are not going to be able to reverse the entire problem, not only for any one individual, but not for this entire generation. That we're going to have to slowly change the epigenetic input that is happening generation by generation until we can recover again as a species
Yep.
to be less susceptible to these problems. We're kind of an inventive lot, and maybe we'll come up with some other way of taming inflammation that will be helpful. But we're also not very good at looking at the long term.
No, I was going to say the consumer has to be educated too.
The consumer, the politicians can't think past an election cycle.
Yep.
Businesses can't think past their quarterly earnings reports to the shareholders. It's really a problem, and it is the source of this problem in the first place. That everything has to be done quickly, cheaply, easily to be good. And that's why we're eating food that's not food. That's why we're breathing air that's laden with particulates. That's why we're living in houses that get moldy. I mean, there's just so many things about what we do that we have to change as a culture in order for us to get past this problem. And there's a part of me that's not particularly hopeful, but there's that other part of me that says my purpose in life is to leave the world a little bit better than I found it.
Yeah.
And for whatever it's worth, that's what I'm gonna do.
Oh, I think that's great.
So can you tell us a little bit about what appliances that you incorporate into some of your treatment plans that differ from what we see a lot on Long Island, which
Yeah,
is rapid palatal expanders?
yeah. So, and I'm not going to vilify rapid palatal expanders by any means.
Mhm.
Let me give you just sort of a brief overview of the range of appliances that from there are there are ways of encouraging the jaws to grow naturally
Okay.
that just by establishing nasal breathing and tongue posture and proper swallowing, a face can grow better. It doesn't require any appliances, but there, but sometimes that's not enough, and it depends on the level of distress that a child is in.
Mhm.
So above natural means, there's something we call biomimetics. And that is, as we learn about the biology of bone growth, we can mimic some of the inputs that are going to the jaws in a way that will help reestablish good growth. So in biomimetics, I guess the go-to is the ALF. The the ALF is a light wire appliance that was designed to enhance mechanotransduction to the bones such that they understand that they're supposed to grow wider, broader, more forward.
Okay.
In essence, it is a surrogate for the tongue.
Right.
We don't use the ALF to make the jawbone grow, and we don't use it to make the jawbone grow wider. We use it to change the direction of growth. And really, in a way, the adjustments of the ALF are to keep up with the natural growth, not to create natural growth, but just
Okay.
to keep up with it in the right direction.
Mhm.
We also do myofunctional therapy, and I use myofunctional orthodontic appliances, the mouthpieces that the kids will wear to teach those four major goals of Myo. That is, breathe through the nose, keep the lips together at rest, keep the tongue on the palate at least 6 to 8 hours a day, teeth in or near contact, and be able to swallow without having to scrunch your face up to do it.
Yep.
Yeah. So that's biomimetics. Now, the next step is where I kind of push a little bit more on the body, where we want to get growth, not so much, you know, not like rapid palatal expansion, but say slow palatal expansion or semi-rapid or whatever it is. But the goal here is not just expansion. The maxilla, when it collapses, it's collapsing in all three dimensions of space.
Okay.
It's not just width. You
Mhm.
say, oh, they got a narrow palate. Well, that's what you're looking at. But if you look at the skull in three dimensions,
Mhm.
it's easy to see that the maxilla not only gets narrower because the tongue's not up there, it fails to grow forward. So sagittally, it's deficient, and it sags vertically. It's like
Okay.
imagine a skull made out of chocolate, and
Okay.
you put it outside on a hot summer day,
Mhm.
and you watch it begin to melt.
Okay.
That's what's going on to our skulls,
Mhm.
Okay.
just metaphorically speaking.
Yeah.
Um, and so the best techniques for growth guidance are to help recover the three-dimensional changes of the maxilla,
Mhm.
and then to help the mandible either cope or catch up or whatever, because the poor mandibles just tends to either struggle, under a collapsing maxilla.
Right.
I mean, more often than not. Sometimes it escapes the drama, and that's when you have these mid-face class 3 underbites and all that.
Mm-hmm.
My favorite appliance in that category is the BioBlock, which is a removable appliance. When I first heard about it and saw it, I go, it's just a removable expander. But like a lot of things, it's not so much in the gadget, but what you're trying to do with it.
Okay.
And of all the appliances that I know, the BioBlock can restore the maxilla in 3 dimensions of space if your timing is correct.
Okay.
And it can help the mandible come forward if genetics allows, without pushing the maxilla back.
Okay.
That's an important nuance, because a lot of people that do growth guidance, they use functional appliances, bionators, herps, Frankels, orthopedic correctors, twin blocks. It's a whole series of these things. But in order to work, they almost always anchor the mandible to the maxilla. You push the mandible forward, but it leans back on the maxilla. And according to the principles of, according to the way the maxilla is collapsing, even if there's a lot of overbite, the maxilla is never too big. It's
Okay.
always deficient, just maybe a little less deficient than the mandible. So you don't want to push backward on the maxilla. And Lord knows I will never use a cervical headgear again in my life,
Okay.
because that's been used to stunt a stunted bone, essentially. Right?
That was so
You know
common
what I'm
when I was
talking
young.
about? Huh?
That was so common when I was young. Everyone was in a headgear.
Because they thought that the overbite had to be corrected.
Yeah.
Dentally, you would push back on what was mistakenly thought of as a protrusive upper jaw.
Yeah.
Now we know that the jaw is retrusive. In fact, if we're going to use any kind of headgear, we use one that pulls the upper jaw forward.
I
There's another
definitely
torture
feel like
surgery.
there's more people in ortho than I've ever seen before, and definitely in multiple rounds of ortho. Or phases of ortho. Do you think that is people being proactive and they're trying to support airway growth, or are those practitioners really just looking at it from a crooked teeth perspective?
I want to answer that, but let me just finish my answer to the last question.
Oh, okay. I'm sorry. Yep.
Because we've talked about natural growth, biomimetics, growth guidance. The next step along the line is orthopedic correction. So orthopedic correction, that's rapid palatal expanders. And I happen to use them quite a bit. Maybe not in a majority anymore, because kids come to me younger and younger. But one of the best indications for rapid palatal expander is when a child is in a significant amount of distress.
Okay.
When I say distress, it can be physical distress as well as mental distress. In fact, it's, the precursor for the mental distress is physical distress.
Right.
But the worse off they are, the more they're struggling to sleep, to breathe, to get along during the day, the more likely I am to pick a rapid palatal expander, because it efficiently and quickly opens the nose, opens the airway, gets room for the tongue in the front of the mouth, and takes the tongue out of the back of the throat. And we've gotten to a point where, depending on the age, we now know how to attach these rapid palatal expanders, not to the teeth, where they put tremendous amounts of pressure on teeth and their roots,
Mhm.
but directly to the jawbone,
Mm,
where it can put the pressure to spread the bones exactly where it's needed.
Mhm.
I feel like I've become literally twice as efficient at opening palates as I used to be. And I no longer have to stop where there's just enough room for the teeth.
Mhm.
I think a lot of orthodontists, well, for a while, we'd only use rapid palatal expanders if there was a posterior crossbite,
yeah,
Mhm.
we've heard that
right?
way too many times.
Yeah.
Yep.
Yeah. And Jim McNamara out of University of Michigan published, oh gosh, this is in the 80s, that you can do palatal expansion not in the not in the presence of crossbite, uh, and he illustrated the various reasons why upper jaw can be narrow and there is no crossbite, especially if the lower jaw compensates.
Yep.
And that would be because the muscles would be equivalent on both sides and make the posterior teeth tip inward on both sides.
Yep.
So whether there's a crossbite or not, it's just, it's really about the width of the maxilla. Um, and so I was doing rapid palatal expansion for a long time in my earlier career. But this idea that you can expand the maxilla back to at least somewhat to its anthropologic standard is a new way of thinking. And it scares a lot of orthodontists because, frankly, it will often make the teeth look a lot worse before they get better.
I was just going to ask
And
that. So is that going to be what the change is? Is it's not going to be about fixing the crooked teeth? It's going to be just about the airway?
well, yeah, I mean, but not just about the airway, but primarily about the airway.
Yes.
And it may take a lot longer for a mandible to recover than it takes for you to get the upper jaw back to where it's supposed to be.
Right.
Or that also scares the crap out of orthodontists
Mhm.
because we have predicated our popularity on being quick, efficient, and easy and cheap.
Oh, yeah. You forgot the bet. Yes. The last one.
Yeah, yeah. Even though it's expensive, it's not
Yes.
nearly as the fees have not risen nearly as fast as the rest of things in our society um, have. And to change a treatment plan that's no longer easy, no longer quick, no longer predictable, no longer cheap, frankly.
Yep.
I mean, I feel like I took the hard road. Everything I got everything working against me. But I can address things that they would never and don't want to
Right.
and argue against,
Yep.
the things that have to be addressed. So my treatment plans, they can run for years and years. Not that I keep them in appliances for years and years, but like for boys, their mandible will continue to grow well through adolescence.
Yep.
So I don't feel like I have to have perfect overbite or class one occlusion when I'm done with treatment because I want to help that jaw continue to grow so that the face can continue to function properly and get more optimal with growth rather than less.
What's interesting is
It's a hard go for orthodontists to understand that because they were trained to look at the teeth. And now the teeth are not the guidance that they thought. This whole thing about angle classification, I think, is a red herring. It's a descriptor of a phenotype. It's what happens to the teeth when they don't come in straight. And it is kind of important to know, but it has nothing to do with the etiology of the problem.
right.
And so it leads orthodontists down a false path.
Yep.
And I mean, that's hard to break here. It took a long, long time for me to get that. I hope to shorten that
Yeah.
trajectory for orthodontists
Mhm.
that will listen.
Yep.
But that's the kind of change in thinking that we need. The physicians have to go through the same change in thinking.
Agreed.
Yeah.
Mhm.
The only ones who don't really have to go through a change in thinking are the chiropractors,
Mhm. Mhm.
because AT still was talking about functionality. Well, I shouldn't say only. The nathologic dentists, the ones that have been doing Crozet since the early 1900s, they have also understood that the body has a certain wisdom to it, and that it doesn't grow well because there are obstacles to that wisdom. And our job is to remove the obstacles and let the body heal itself. That's back at the natural and biomimetic route, right?
Mhm.
Uh, but wait, we have one more category, and that is orthognathic.
Yes.
Mhm.
Orthognathic is where we don't rely on the body's wisdom at all.
Yep.
That it's the doctor's wisdom that's being applied to the body.
That's
And
a place for
we're
us.
the ones who are deciding where the healing should be. We're the ones who are deciding where the bones should be. We're the ones who are deciding what the facial dynamics, I mean, the facial dimensions should be. And we literally take the skull apart and put it back together in that way.
It's insane.
And it can be miraculous. It happens to be the only sure cure for sleep apnea.
Wow.
And even then it only works 85% of the time, but that's good.
Absolutely. Well, it's crazy is because during the pandemic, dentists and orthos were not considered essential. Meanwhile, they're so crucial for breathing purposes,
Mhm.
but we were essential for speech. I'm like, I don't get
Yeah.
it.
Yeah, well, we thought everybody was dying.
Yes, true. Nobody cared about their teeth in those moments.
Yeah, we were deluded to think that this thing was unnatural and was coming to get us, and we wiped down our groceries, for God's sake.
Oh my God, no joke. Yeah, we wore masks outside.
But
I mean, can't get better
yeah,
than that.
whatever.
We're
So
gonna need to do a
anyway,
part two because there's so much
uh,
more we want to ask you, but I know you are have
oh
a
really?
hard 12 and we have a hard stop at 12 too.
Oh, okay.
But
Mhm.
Yeah,
we definitely do
I'll
a
be
second
happy
one.
to do it again.
All right, we liked it. It's fun. It's
Yeah.
nice
Yeah,
to just have conversation.
yeah.
Um,
And let me tell your audience that I
yeah.
did have a fantasy that lasted for a few days
Uh-oh.
We know what
of you and I were of you guys and I working together in a collaborative way.
Mhm.
And I mentioned it because the timing just wasn't right. But I
Yes.
had a space in my office that I had used for teaching and myofunctional training, and I lost it. And I lost it to a lawyer, for God's sakes. And but my dream, and I'm thinking it's yours too, that the idea that the best way to treat children will be a collaborative approach where kids can get services to help their structure, their function, their behavior,
Mhm.
and help them through this chronic problem.
Absolutely.
We've gotten a lot of kickback from, I shouldn't say a lot, but we've had kickback from some myofunctional therapists, especially about Spot Pal, because they said, if you knew anything about myofunctional therapy, you wouldn't be encouraging the pokes or what have you. And the hardest
Yeah,
part about, I think for us, especially with Spot Pal, is that we're trying to help 90% of the population too that cannot get services. So we
yeah,
have to kind of like pick and choose which one, or use it for the benefit of both when you can, or when
yeah,
otherwise you can't. But if we can make a small difference,
yeah,
it's better than nothing.
Mhm.
yeah. Yeah, I see your point, and you guys certainly know about myofunctional therapy. There's no question about that. There will have to be cultural compensations that we have to make so that people can avail themselves of good treatment. You know, the toothbrush is a perfect example.
Yep.
And I'm pretty sure there were dentists who argued that the toothbrush was insufficient and why should we use it, when it first came out.
Yeah.
And a toothbrush has never put a dentist out of business, unfortunately.
No, definitely not.
And
Exactly.
right. And so, but I think, these training devices like the ones, the rubber mouthpieces that you put in, I think they will become as ubiquitous as pacifiers someday too. You'll be able to buy those things in Walmart and the pharmacies and supermarkets, because moms are going to know, yeah, we got to get the kid breathing through their nose.
Yep. And they're
And
definitely become more knowledgeable.
and they're going to become more knowledgeable. So all of these things are going to be really helpful. I Spot Pal, for me, it was great because I had a patient going to Florida, and she wasn't in a spot. She wasn't in a place where she'd be able to get up, and I couldn't find anybody down there for her in this particular area. And Spot Pal came in, right on the spot.
Perfect.
And helped her continue her treatment. So.
Thank you for joining us on this episode of Talk the Talk.
We hope it was enjoyable and educational and further supports you both personally and professionally.
For more information, please check out our Myo and Myo Minute podcast, as well as our other episodes of Talk the Talk. And don't forget to check out our tongue training appliance, Spot Pal, to help with tongue thrusting, thumb sucking, snoring, TMJ, mouth breathing, and so much more. Visit thespotpal.com.